Hey everyone, we're going to discuss a clinical simulation about a fella that is 54 years old. He's worked in a restaurant now for about 34 years, so since he was in college. And though he hasn't smoked, a lot of people that he worked with has. And it's been during that era that people were allowed to smoke inside until about 5 years ago or so. Plus, he's been exposed to a lot of smoke from the grill and just from out in the front of the house, or what they would call the dining area. Uh, it wasn't that long ago that people could smoke in certain areas in a restaurant or just out in the open in a restaurant. So he's been exposed to this all these years. And he comes into the emergency room complaining that he has an inability to walk up a flight of stairs when he goes out on the weekends. He has to stop and can't catch his breath. So this information tells us he's got a couple of different issues going on. First, he's had a lot of exposure occupationally to cigarette smoke and to the smoke of interior grill use, and he's also has a cardiac issue. Now, how do we know that? Because when the NBRC talks about an inability to walk up a flight of stairs, then they want you to immediately flag for a cardiac issue. So he probably has COPD related issues from the tobacco exposure and from the grill exposure, plus the cardiac issues due to the exertion on the stairs complaint. And so he has severe shortness of breath, and we are going to decide what we're going to evaluate about him. So the first thing we're going to do when we go into the room is evaluate what we can see from the door or from the bedside. That is both fast, quick, easy, and, well, that's also cheap. Okay, so what things are those? Well, we're going to choose general appearance, and it tells us that he's diaphoretic, which means he's sweating profusely. He's tachypnic, which means he's breathing faster than normal. He's taking shallow breaths, which means that he's unable to take a deep breath in or out. He has accessory muscle use. His vital signs are 100, and his heart rate's 132. His respiratory rate's 38. His blood pressure is 152 over 84. His temp is 101.2. His chest configuration, he has an increased AP diameter. That's our key word there to tell us that there is probably COPD. He has air trapping that's increased his chest circumference. So right now we've already decided that he's under distress because his vitals are up. He has an infection likely because his temp is up, and he has an increased AP diameter, which tells us that there's a chronic issue as well. His emotional state, well, he's anxious and mildly confused, and that's understandable. His breath sounds are markedly diminished bilaterally with a few bibasilar crackles. Again, there's our sign that there's likely a cardiac issue. The crackles are going to be from some congestive heart failure or pulmonary edema. And we're going to go ahead and also choose an EKG, which tells us that he has sinus tachycardia. We already know that because his heart rate's up above 130. Anything over 120 is definitely tachycardia. His x-ray shows that he has mild to moderate hyperinflation, which tells us there's COPD involved. Increased vascular markings, again another sign of cardiac disease. Bibasilar infiltrates tells us there's what's causing the temperature issue. He's febrile because he has bibasilar infiltrates, so he has a pneumonia as well. This fella's having a rough day, right? There's a patchy infiltrate in the left upper lobe. That again tells us there's pneumonia. So he has the left upper lobe pneumonia, and the bibasilar infiltrates can be a pneumonia or it could be fluid. Either one of them can be listed that way. The ABG, we're going to go ahead and check that on 2 liters via nasal cannula. His pH is 7.29. His PCO2 is 79. Ooh, that's a big red flag, both of those. His PO2 is 47. He's definitely hypoxemic. His bicarb's 40. So that's telling us that this is an acute on chronic situation. When we examine his extremities, there's mild cyanosis of the nail beds. He has pedal edema +3, which tells us there's heart failure involved. He also has clubbing in the fingertips, which tells us this is a chronic issue. Our decision-making choices we're going to make now when we look at all of our information that we just went over. It gives us a choice. Do we want to apply 6 liters of oxygen and do an ABG in 20 minutes? Let's not do that, because that's going to cause him to go farther into respiratory failure. His PCO2 is going to keep climbing up. He's going to hypoventilate due to his hypoxic drive issues. Do we want to administer albuterol? Well, it didn't really tell us that there is wheezing, so there's no need for that. Intubate and mechanically ventilate? Yes, we're going to go ahead and do that. Because that's the best plan for acute hypercapnic and hypoxemic respiratory failure. We're going to also administer some furosemide. We're going to stimulate the kidneys to diurese and help the patient urinate that extra fluid overload off. It will reduce the fluid overload, but the patient, the priority is that the patient's in acute respiratory failure. So you don't have to choose the furosemide, but you can choose it, and it will just give you an extra step. It will not count against you, but it doesn't give you any extra points either, because they want you to prioritize to intubate and mechanically ventilate. And we would, in the clinical setting, we would give him furosemide or Lasix. But the first step that they want you to choose here is to intubate and stabilize the patient. The other choices it gives is to apply 100% non-rebreather. That would cost you a couple points. We don't want to do that either. Like the 6 liters, that would make his respiratory failure worse and just accelerate the hypoventilation and hypercarbia and the acidic pH. It gives us the opportunity to administer IV antibiotics. We know, just like the furosemide, we know we do need IV antibiotics because he's febrile and he does have that left upper lobe infiltrate, but we want to prioritize by intubating and mechanically ventilating, because IV antibiotics will be a part of his care plan, but they will take time to take effect. They will be helpful, but they will not remedy this issue emergently. The issue at hand is respiratory failure, and we definitely do not want to delay treatment by doing anything other than intubating and mechanically ventilating the patient. Okay? All right. Well, thanks for listening. I hope that's helpful to you. We want to make sure that you subscribe below for future recordings, and definitely join our study group over at RRT and Neonatal Pediatric Respiratory Therapy Review. We'd be glad to have you, and we play live games quite often, and we have daily updates with lots of questions that we discuss online. And we're a fun bunch, and we're a big RT family, okay? So come on over and join us, and comment with any questions below. Thanks for listening.